Dr. Deuk. I'm here with my team. We're just another little bit of numbing medicine.
Numbing medicine, you're okay.
And we're going to be doing what's called a Deuk laser disc repair on our patient, who is basically, he has 2 herniated discs. They're really more disc bulges, and they're causing a lot of pain for him in his back. He injured his back at work, and he wants to get it fixed. So we're here to do that for him. Yeah. All right. You're welcome. Just lay still, num medicine. You're doing great. Lay still, okay? All right. So we're going to give our patient some more numbing medicine. He is awake partially. We call it sedated shot. You're doing great. Just lay still. So the first part of the surgery, which is done by Luis, is just positioning, prepping, and draping the patient, getting him in a position where we can do the surgery, and getting his back cleaned so that we can do it safely. We use an antiseptic, and now second part of the surgery is navigating down to the discs that need to be repaired. And the first one we're going to go to is the L4-5 on the right side. Now he has a herniation at L4-5 on the right, shot, and L3-4 on the left. Shot. 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 So you can see the spinal needle is close to the L4-5 disc. We're going through what's called the foramen to get down to the disc. Are you comfortable? Shot? Huh? Sleepy? And right now I'm up against the superior facet. I need to redirect just a little bit. Shot? Can you try not to get my hand? So one thing I'm asking you to please do. Shot. What? That's exactly what you have to do. Shot. 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 How's he doing?
Okay.
Shot. All right, the disc is lined up. Once again, just encountering the facet joints, I just need to be a little bit more anterior. Shot. Doing okay over there? Good to hear. Shot. We're getting there. Shot. Is he okay?
Yep.
Reliable for us to shot. I can feel the herniation right here. All right. So, Luis, you agree we're at 4-5?
Yes, sir. Yes, sir.
And that 4-5, we're supposed to be on the right side. Everyone agrees?
Yes, sir.
All right. Shot. Is he okay? Yeah, I can feel the herniation right there. Surprising that he's so deep, you know, but his spine is deep. He's not a big guy. I mean, he's not huge by any means, but what this means is the spine is very anterior. All right, next we're going to go for the 3-4. So that's the next disc up. Now he does have a smaller herniation up there, but it is significant. Shot. That's too far north. How's our blood pressure? A little pressure here.
Yes, sir.
Your left hand. Lay still. You're doing great. Don't move. Shot. Shot. wonder if I should start a little bit lower. All right, let's do some numbing medicine for the skin. I'm going to start a little bit lower. You're okay. We're just giving you some more numbing medicine. So the first thing we're doing is we're just numbing up the skin and soft tissues to make it a little bit more comfortable for them.
Great, buddy. Just keep your head
Yeah, everything's okay.
down. Great.
And this numbing medicine contains epinephrine and lidocaine and marcaine. Thanks, Luis. Little pressure. Whereas the stuff we use deeper doesn't have the epinephrine. And, you know, honestly, I think his spine is interesting because the L5-S1 disc is usually gets injured pretty easily, shot. But in his case, it's not. It's pretty well preserved, and I think it's because it's not a real disc. I think it's possibly a fused disc, one that was never mobile. Shot? 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 I'm feeling the superior facet. Shot? Shot? All right, so you can see the herniation right there, right in front of the needle tip at 3-4. Shot? And then AP. Let's go to an AP. So at 3-4, you can actually kind of make out a disc bulge, herniation, just in front of the needle tip, which means from your view to the left of the needle tip at L3-4. Yeah, it's perfect. You can see the needle position is perfect. If you were here earlier for our first case, it was a thoracic. I could not get the needle to this position, which is the mid-pedicular line, right where the disc starts, and the reason was it was being deflected by the facet. So yeah, this is really, really good. Very happy with this. Shot. There's the herniation right there, and we'll go in through the tear. All right, we're ready for him to be awake whenever you're ready. More awake, I should say, more responsive. All right, can you guys see okay, Flynn? So to teach everybody, I'm going to do a little drawing here. 80% of lower back pain that people have, chronic lower back pain, it comes from a herniated disc. Okay? And there's different names for the herniated disc: bulging disc, herniated disc, ruptured disc, protruded disc, extruded disc, slip disc. There's literally 10 different names for the same thing, but they're all herniated discs. The second most common cause of back pain is facet syndrome. Arthritis in the facet joints, it accounts for 15% of back pain. So between these two, you've got 95% of chronic lower back pain. There's another cause that's common. It's a fracture of the vertebral body, and that accounts for about 4%. So when you add in fractures of the vertebral body, you're at 99% of the causes of back pain. These are easy to see. Now, herniated disc and facet syndrome are hard to treat, hard to diagnose, but we do it all the time. Today, our patient is having disc pain from a herniated disc at L3-4 and L4-5. So let me draw those discs on this surface here. There's one disc, and there's the other disc. Okay, this is the L4-5, and this is the L3-4. Now, right now we're in a unique position where we can test these herniated discs and see, are they actually causing his pain? Are you awake?
Hey, John. Hold up. John. ¿Cómo se siente? ¿Bien? ¿Está bien?
So our anesthesiologist has the patient extremely comfortable, which is wonderful. And now we just want to verify, that these discs are indeed causing his pain in his back. Do we know how long he's had back pain for, based on the H&P?
He injured it at work. He thinks
A work injury. Was it 10 years ago he had a work injury? Oh, September. All right. About a year ago. So he injured his back a year ago at work and began developing back pain. And he's tried conservative treatment. He's here now because the conservative treatment doesn't really work. So he's going to have the Deuk laser disc repair. So what are we going to do today? We're going to go into this disc and we're literally going to remove the herniation with a laser. You'll see it. It'll be in pieces. It'll be blue. And we're also going to clean the annular tear out. We're going to do that on the left side at L3-4 and we're going to do it on the right side at L4-5. How are we doing?
Here you go.
Are you awake?
Awake? Okay. Don't
He's
move your
moving
head.
around. Don't move. You're doing great. Just lay still. All right. So I'd like to see the sacrum a little bit better. I want to make 100% sure we're at the right level. Now you can see there's a disc down below. It's not really well visualized. And I believe that may be a pseudo disc, but that is the L5-S1 disc, what we're calling. So we are at 3, 4, and 4, 5. Perfect. You can go back and show us the disc that we're at. All right. You okay?
You said yes.
Are you in pain?
You having pain? No.
All right, good. Just relax, lay still, okay? Are we ready? You can see his back arching up. How bad is that on a scale of 1 to 10?
0 to 10. Is that 10? How bad is your pain? 8.
8. Is that where you get back pain? Typically?
Is that where your pain is normal? Yes.
Okay, good. That's one of the bad discs. We're going to fix it. That's 8 out of 10 concordant at L4-5. Good job. So we know that the L4-5 disc at this point is definitely causing his pain that he gets every day. That's why we ask him, is that where you typically get pain?
And we're going to try the next one.
No, you
okay?
don't tell him that. You don't tell him that. We don't want to warn him. Just want to know, is the pain gone? Is the pain gone?
No pain? No.
Look at this. What a patriot. You know, red, white, and blue. You okay?
Yeah.
Yeah. How bad is that on a scale of 1 to 10?
Huh? 0.
0. Okay. No back pain. No back pain? All right. So 3-4 is not causing back pain, but there is a herniated disc that's pinching his nerve. So we're not going to treat 3-4 herniation for back pain. We're going to treat it for radiculopathy only. So no pain, right at there?
No pain.
Nothing? Okay, good. So 3-4 is 0 over 10 for back pain?
Do I write
Just put 0 over 10.
cordon or just?
No, it's not discordant. Discordant means he would have pain, but it's not his typical pain. Yeah, so you're just going to write no pain. No back pain. All right, we're going to put you to sleep. When you wake up, we'll be done. I want you to count from 1 to 100 in Spanish. Can you do that for me? Laser on.
Yeah,
Shot.
you stay here, Monica.
By the way, we're broadcasting live, so you can ask questions and you can watch the surgery
Picture, your picture.
and see how we do these surgeries.
Can you turn on the machine, please? Thank you.
We're going to get started with our first disc.
Thank you.
Is he asleep already?
Give no. Giving him this.
Because he's not counting. All right, so what we know from our discogram is that the L4-5 disc is causing all of his back pain, and both discs are causing his leg pain, which is on both sides. But the 3-4 is not causing back pain, it's just causing left leg pain. You can see the herniation there at 3-4. It's pretty big. It's hitting the nerve root. Show the audience on that x-ray. Are you back at the x-ray, Flynn? Don't take another x-ray. Just, show the audience the x-ray. Oh, that last one was so much better. You just hit the shot again, right?
Yes.
I didn't want you to hit the shot again.
Sorry.
Give me the die. You're killing me. Everyone wants to make my life hard today. Shot. Can't really see it. It was so nice before. Shot. Oh well.
Looks like a bird.
Hmm?
Looks like a bird, like a dove.
Yeah, well, you can see the herniation. Go ahead and show them the herniation in the foramen. No, at 3-4. Yeah, that's right. Show them the back right there. Look, that go to the right. Stop right there. That piece right by the arrow is hitting the nerve. Show them where the nerve is, just a little bit above. A little higher. A little higher. Right there. So that herniation is hitting the nerve in the neuroforamen. That's why the patient has left leg symptoms. All right, we're going back to the right side. We'll get to the left side shortly. We're going to start with this disc, L4-5, the bottom one, which is causing his back pain and right leg pain. Shot? Okay, so at this point we're sitting at the tear where the herniation came out. I'm literally touching against the herniation, and I'm going to push the piece of herniation back in, and then I'm going to get it out from the inside later. This is called the inside-out technique. It's a safer technique than outside in my opinion. Some surgeons like the outside in, where they start in the foramen and they work their way. Take that. Take that. They work their way from the foramen down to the herniation. Yep. You can do it, Luis. You don't have to wait for me. Go ahead.
You're gonna present it to the public.
Right now we're placing our endoscopic tube called the tubular retractor is going down over the dilator. And we're going to be advancing that. Shot. We're watching it on the x-ray. You can see it just starting to enter through the herniation in the back of the disc. Remember, the herniation comes out through a tear. That's good. The tear itself is not a herniation, it's a tear. It's called an annular tear.
Yeah.
Only when the nuclear material pushes through the tear do you get symptoms. The symptoms people typically get are back pain and leg pain or numbness, tingling, weakness in their leg. They're called radicular symptoms.
Yeah, yeah.
Everything okay, guys and gals?
Yeah.
All right, so for those of you who've never seen an endoscope, this is what it looks like. Can you see this, Flynn? All right, this is the endoscope. It's got rods and lenses. This is the rod, the metal rod or shaft, and then the lenses are inside. There's also a working channel here and a place for light to come in. Let's go ahead and turn the scope on. I'm going to show you guys how it lights. It is, all right, good. See how the scope can create light right at the tip. That way we can use that illumination to see inside the disc herniation itself. Why don't you show our audience, Flynn, with one of our animations? How does a annular tear and herniation cause back pain? Before you do that, though, I want you to look at this picture here very carefully. And let me explain it to you. Can you see the endoscope? This picture has everything you need to know.
What is it?
I want the laser fiber.
Yes, sir.
All right, there's three colors. It's red, white, and blue, right? Very patriotic. The white over here is actually the annulus fibrosus. That's what's torn. It's torn right there. And the blue is the nucleus pulposus. And it's literally stuck to the tear with scar tissue from inflammation. The pink is granulation tissue. It has little nerve fibers in it. And that's the part of the tear and herniation that causes all the pain. That's not blood. That's granulation tissue. And that's where the pain comes from. So we're going to zap all this away, clean it up. When we're done, his back pain will be gone and his leg pain will be gone. People out there with a herniated or bulging disc, when you have back pain, this is what it's coming from. We can see it endoscopically and we can fix it with the Deuk laser disc repair procedure. The Deuk laser disc repair is the only surgery in the world that cleans the tear. It's called an annular debridement. It's the only surgery in the world that actually addresses the source of pain. That's because we discovered the source of pain here at Deuk Spine. Disc is the source of pain, but they don't understand what part of the herniated disc actually causes the pain. It's not the whole disc, it's just the part in the back. And that part in the back where the tear is inflamed, and that's where all the back pain comes from. Same thing in the neck, same thing in the thoracic spine.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. We are using the pituitary to remove pieces of herniation. As you can see, the pituitary is not very effective by itself. That's why we use the laser. The laser does 95% of the work with the Deuk laser disc repair. Without it, the surgery is not possible to do. Once again, there's the tear. You can see the granulation tissue. These are really good pictures right here, Flynn. That's beautiful. That tells the whole story right there. Inflammation within the annular tear seen as granulation tissue, the pink stuff. So without the laser, it's not possible to do the debridement. And the pituitary rongeur really just grabs out big pieces, pulls them out. Put it in my hand, please. Don't just hold it there. Okay? Do you understand the difference? What is the difference? Huh? Yeah, why is that? Let's say you hold it there. What do I have to do? I have to look. You understand? And
So before I put it over here, I'd rather show that. Yeah, yeah, put it over here.
can't get it where I need it, Luis.
Yeah, right there.
I need it to go. There we go. That's a little better. Yeah,
Better?
that's better. Why don't you show our audience, Flynn, what the Deuk laser disc repair is, how it works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Yeah, we were just talking about the patient. He's doing very well. He's comfortably snoring and sleeping like a baby. We are getting closer to the outside of the disc where more of the pain fibers are, and Dr. Berndes knows this. He's gonna make sure the patient remains comfortable, doesn't try to come off the bed. All right, the nerve root is going to be in that fat right there. We want to keep it there and keep it safe, right outside the tube. All right, all done. That's where the herniation was, right there.
Lights on, please.
We're done.
Thank you.
Yep. Now we have the other side to do at L3-4. No, it's not hard. It's not hard. It's always the same exact thing. Once we get towards the outside of the disc, you know they're going to have problems. The doctor who did the most of these with me, Dr. Santiago, he anticipated everything. He knew it was coming. He had just hit him with some more right before I got close to the outside of the disc. I had one anesthesiologist who never even put the patient to sleep. They just stayed awake the whole time.
Really? Wow.
Remember that?
How did you do the case?
Oh, 5 cases, all the same. Because if you don't put the patient asleep, you're never going to have an anesthesia complication. Except maybe their heart rate goes up, but you give them beta blocker. So it's not really anesthesia, is it? But it keeps them from having a complication from anesthesia.
What about the surgical complication?
They don't care. It's all about finding it balanced, or it's just right.
Are you serious?
I think that 200 profile went in his arm.
How much do I go? Yeah, it's way more.
You're way too high. Did you drop your fluoro before you take that picture? All right, go ahead. Yeah, I would move north. I'm going to switch sides so that I can do the surgery from the left side. I was on the right side. And there's our picture. I'm going to go ahead and get rid of this needle. We've got a guide wire now shot. Looks good. Everyone agree, left 3-4? Everyone agree, left 3-4? Shot. So remember, we tested this disc earlier. There's no back pain from it, but there is leg pain from the nerve being pinched. Shot. How are we doing, doctor? Why don't you go help him? Oh. Want me to wait or give him some stimulation? Shot? Good. We're in. Tell me whatever you need me to do. Do I need to come? Are you bringing them back?
Yep.
You want to get the gurney in, or
I think we got it back. Yeah.
give him a little more stimulation?
Yep.
Shot?
Monica, we need the pedal over there. We need your arm.
Okay.
Thank you. There. Are you good? And then we need the end of
What he
the
told me, just when you're ready, is he used to just give a little bit at the right time, is what he said. I always ask him, how do you get it so right, you know? Just give a little bit at the right time. You doing all right? Is he moving air?
end of.
Now come back here for the pedal.
We need the end of the over there. Thank you. End of the small bones, right? Thank you.
We okay? All right, we'll be done quickly here as long as I can get the video feed.
Awesome. Thank you.
All right, laser. Luis, why don't you come,
Yeah, yeah.
unless you're busy with something.
Help or doing this?
Yeah,
Huh? Help them?
yeah. No, help. Do you guys need Luis's help? Help Oscar. You do it. This is not time for Oscar to learn.
Okay.
I need a experienced assistant right now. We want to get this done, get this patient back on the bed. Does he have sleep apnea?
If we can skip that test.
He's got it. All right.
Oscar cleavage, or we have to?
Do you want Oscar to scrub out?
I don't know, maybe, just so we can make sure we have everything ready to flip really quick.
Yep, go scrub out, Oscar.
Yeah.
Get the gurney ready. You guys want the fluoro out of the way?
Yes. Yeah. Yeah. Monica.
Monte X-ray? Yeah.
So this is the part of the herniation on the left at L3-4. It's really firm,
Control the laser on
really, really hard. This is what was pushing on the nerve.
standby.
And remember when I went into the disc, I hammered the dilator in. That's actually pushing the herniation back into the disc right where we are. So I'm able to remove it safely without being anywhere near the nerves. Thanks. I won't back up. I'll be fine.
It's fine. No, we don't need the gurney. Stop. Everything's fine.
Well, just get everything ready, you know. This should be a relatively quick disc, I hope.
To be a distraction. It's fine.
Huh?
It's fine right now. If I need the gurney, I'll be calling. That's all right? No, no, that's fine. That's it. Thank you, though. Thank you very much. Thank you.
That was a nice herniation piece coming out. I think about 5 minutes, doctor. So in about 4 minutes, I should be up against the outer wall again.
Thank you.
The thing about it, though, is this one doesn't seem to be bothering him as much from a back pain standpoint. I want to grab her. Piece of herniation here. The blue stuff. And the blue dye is the dye that's a Deuk spine dye. It stains degenerated nucleus pulposus. Does not stain annulus. Does not stain healthy nuclear material. Does not stain the bone. The only thing it stains blue is kind of the bad stuff, basically. Kind of makes it easier for me to target what needs to come out. If you have questions, feel free to type them up for me. I'll be over there in 10 minutes to answer them for you. I've got 5 minutes, maybe 4 minutes left here. I'm just going to take a peek. It looks like we're just about in the epidural space right outside the disc at the 12 o'clock position there. But feel free to type up your questions. Like I said, I'll be happy to answer them. Anything related to the spine, it could be related to medications or therapy or injections or pain management treatments. I'll do my best to answer them. If it's related to spine surgery, I usually know that stuff pretty cold, but I'll do my best to answer any of your questions, okay? These are free broadcasts that we do for public education. We don't get paid for any of them. We don't make any money off of them. We just try to help people get their questions answered. The reason why is I recognize out there's so much misinformation about back and neck problems, with the spine that we want to clear things up and make sure people have access to factual, truthful information. So, you know, the other thing I could be doing during surgery is singing, and I don't make a very good singer. So the more you guys ask questions, the happier my staff are. 2 minutes? Why? 1 minute, 43.89887868584848.
I'm gonna switch
Hey.
to irrigation.
Oh, you're gonna hold me to it, huh? Get a stopwatch out? Is that what you're gonna do?
What is it?
You're gonna get a stopwatch out and check?
No, I say we're done today at 4:30. Look.
Where are we getting the clicker from?
It's pretty good. Why, do you have a bet?
No, but
Oh, you
don't
should have
make
made a
me-
bet.
Don't make me lose it.
Huh?
I don't bet.
No.
Uh-oh, Luis, it's 4:31.
Shut up.
Oh, really? Was it 4:30? Louise said we'll be done by
That's what
4:30.
he said, yeah.
I see.
In my head, I finished the day.
Well, in all fairness to Louise, we had some issues we had to deal with today, so I think Louise did a darn good job of predicting what time we'd be done. You don't want to know what time I thought we'd be done. Try 3.
That's a joke.
That's actually funny.
Alright. Now it kind of.
I was too optimistic, huh?
I thought that first case would go faster. I thought you were gonna do it right.
20 minutes.
We spent an hour and a half on that guy and didn't even get it. That was depressing for me. All right, it looks like we're done here. Let me just make sure that's not a big herniation right there because it's moving. Let me see the grabber. Flynn, do you have any questions? What is it today about our... Sorry, Dr. Berndes. I'm just looking at this.
Say sorry to Luis, he lost the bet.
What's the problem?
He has macroplastia.
Big tongue?
That's never good at the phones. It just falls.
I think we're okay. Yeah.
Hey, you're doing great, my friend. Stop again.
Just about done.
Stop again. No way am I
Let me
sick.
see the laser one more time.
Stop again.
Yeah, we're almost done. Hang in there. You're not gonna like this. I don't see a herniation, but a big one, but see a lot of like collagenization. That should be good.
Okay.
Let's hope that
Nice one,
is.
You. Pop out, please.
All right, Flynn, I'll come over there and answer questions. Our last patient, I think, went home already.
What is it? Yes, I need. I have one. I have one. Yeah. Thank you.
Dude, did you ever see the movie, the biography of Dr. Ben Carson's life? It's on Netflix.
Hmm.
Did you ever see it? I think it's a good one for you to watch.
I met Dr. Ben Carson. Yeah, I interviewed at Johns Hopkins before I took my neurosurgery station at UF in Gainesville. I turned them down. They wanted me to go there. Let's get one more irrigation.
It's called.
You have
it's
any
called
more?
Gifted Hands.
Yeah, I know. That's his book.
It's yeah. They made it. They made it. Wasn't that a great show? I watched it. Yeah.
Yeah, he's a pediatric neurosurgeon. I know a lot about Dr. Carson, things that you don't want me to repeat here.
Okay. I just thought.
I don't want to say anything bad about Dr. Carson. He's accomplished a lot, and I respect him for that.
Yeah, you can move all that one. Let's bring the table here. Thank you.
Yeah, if you call it that. Right? I could run for president too. I may not get any votes, but you could run for
You
president.
might get more than him.
Maybe. Yeah, he's a smart guy. I like him. I don't know why people had such an issue with him, you know? But I don't know. I don't think he's really got the political or politician mentality.
No.
All right, Flynn, why don't you go ahead and
What is it?
yeah, sure. I'm done. I'm coming over right now. Come on over. Oh,
I got it.
I'll hold it. You go. Tell him I'll be there in 10 minutes.
Crystal, you can help me. Yeah, unless somebody can bring
Flynn, go ahead and run our comparison video between the Deuk laser disc repair and spinal fusion, which would be this patient's alternative.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%,
And welcome to our broadcast of live spine surgery happening here at Deuk Spine Institute on July 14, 2022. And we have Flynn sitting in here today for Henry. Henry is out this week and Flynn is covering. So one of our issues, of course, we don't have a microphone in the operating room this week. We're trying to get that rectified, but you know, technology sometimes doesn't work when you need it to. That said, we're here to answer your questions. So if you have any last minute questions, feel free to type them up. Now, we did have a question from one of our audience, which is putting a smile on my face because she's actually a patient in a hospital right now. And she had a fusion done somewhere else out there. I'm not sure exactly where her fusion was done, but in another place. And she's having problems with her leg. She's having numbness and tingling in her leg. And she's asking through this live stream, Dr. Deuk, what's going on with my leg? Any ideas? Can you help me out? This surgeon did the surgery. It's my third surgery done. I had a fusion. I don't even know what level she had fused, but I answered her in the last surgery, but she wasn't there watching, so I'm going to answer it again for her right now. So why do you have numbness and tingling in your legs? The most likely cause is a pinched nerve, or a nerve that's been tampered with during the surgery. Could be crushed. That's the most likely thing. And if you crush a nerve, it's so delicate that you're going to get numbness, tingling, even weakness potentially. When you crush a nerve, a lot of times the nerve will heal over time. It could take 6 months, but the strength and the feeling and the tingling all resolve and it gets back to normal. We call that a neuropraxic injury to the nerve. Neuropraxic. Now, I'm hoping that's all you have. I don't know because I didn't do your surgery. But sometimes surgeons do stupid things. They cut nerves, they get it caught up in a drill or a piece of equipment, and they do permanent damage. So your nerve symptoms in your leg that you're asking me about, they're either going to be temporary or permanent. If it's a light crush, it'll be temporary, it'll recover, it'll take weeks to months. If it's a torn nerve or a damaged nerve, it could be permanent, it won't come back. You'll just have numbness and tingling for a long time. Now, in my experience of treating patients with these types of nerve compression injuries, there's two types. There's those that occur where you're operating at the level of the fusion, and there's those that occur above or below the fusion. And some surgeons kind of miss the narrowing and stenosis going on above the fusion or below, and when the patient's in the operating room, they're laying on a table and they're pinching those nerves at those other levels. It could be also that the screw went through and hit the nerve when he put it in. It could be that when he put the cage in, I'm saying he, it could be a he or she, that cage did damage to the nerve. I don't know exactly why you're having numbness and tingling in your leg, but it's something you need to let your surgeon know immediately that you have that problem. By letting the surgeon know, it gives them the opportunity to run some tests, like x-ray, possibly a CAT scan or an MRI. There's other potential causes like an epidural hematoma, which is a blood clot sitting on top of your nerves, pressing on the nerves, causing the same symptoms. So there's a whole list of potential causes, and I think you need to discuss that with your surgeon so they can start looking for the cause. My assumption would be that this is potentially an emergency situation. You need to get it looked at immediately. And the things that they can do are CAT scan, MRI scan, x-rays. And that's what I would start with if it was my patient. Now, of course, if it was my patient, they wouldn't have these problems, because I would make sure that that didn't happen. I honestly don't know why you're having your nerve symptoms, but once again, got to talk to your surgeon immediately, okay? If it turns out your surgeon can't figure it out, the neurologist can't figure it out, I'm happy to try to help you. You can just send us your MRI after surgery, of course, or even that before may help, but I want the one after as well as a CAT scan. And I can look at it and try to piece together what's going on. I hope you feel better, and I hope your leg starts feeling better. Any other questions?
No other questions.
All right, hope you enjoyed